Today I will be teaching on adverse drug reactions, ADRs, affecting the hematological system, its causes, effects, and clinical management. This is presented by ALES Healthcare. Adverse drug reactions involving the blood and bone marrow can be serious, sometimes life-threatening, and often require prompt recognition and intervention. These reactions may affect red blood cells, RBCs, white blood cells, WBCs, platelets, or bone marrow function as a whole. 1. Aplastic anemia. Aplastic anemia is a condition where the bone marrow fails to produce sufficient blood cells, leading to pancytopenia, reduction in red blood cells, white blood cells, and platelets. Causative drugs. This condition can be triggered by several drug classes, including antidiabetics such as chlorpropamide and tolbutamide, antiepileptics like carbamazepine, phenytoin, and lamotrigine, anti-inflammatory agents including diclofenac, indomethacin, piroxicam, sulindac, and phenylbutazone, antimicrobials such as chloramphenicol, cotrimoxazole, and sulfonamides, antiplatelet drugs like ticlopidine, antipsychotics such as chlorpromazine, antithyroid medications including methimazole and propylthiouracil. Clinical features. Patients typically present with fatigue due to anemia, recurrent infections due to leukopenia, and bleeding tendencies due to thrombocytopenia. Unfortunately, in many cases, the bone marrow damage does not reverse even after stopping the offending drug. 2. Agranulocytosis. Agranulocytosis is characterized by a dangerously low neutrophil count, less than 0.5 times 10 to the power of 9 per liter, significantly increasing infection risk. Causative drugs. Antibiotics such as penicillins, cephalosporins, chloramphenicol, and sulfonamides. Antidepressants including imipramine, clomipramine, and desipramine. Antiepileptics like carbamazepine and phenytoin. Anti-inflammatory and immunomodulating drugs such as gold, leflunomide, and non-steroidal anti-inflammatory drugs. Antipsychotics, especially clozapine and chlorpromazine. Antithyroid drugs like methimazole and propylthiouracil. Clinical features. Patients may develop fever, sore throat, and severe infections. Recovery typically occurs within 2 to 3 weeks after discontinuing the drug. Re-exposure must be avoided because it can lead to a more severe immune reaction. 3. Thrombocytopenia. Thrombocytopenia refers to a platelet count below 150 times 10 to the power of 9 per liter, increasing the risk of bleeding. Causative drugs. Antimicrobials such as chloramphenicol, cotrimoxazole, rifampicin, and penicillins. Antiepileptics like sodium valproate. Anti-inflammatory drugs such as gold and penicillamine. Diuretics including thiazides and furosemide. Other drugs like tolbutamide, digoxin, methyldopa, quinidine, and heparin. Clinical features. Patients may notice easy bruising, nosebleeds, gum bleeding, or purpura. Bleeding time is prolonged, but international normalized ratio remains normal. This condition usually develops within 7 to 10 days of starting the drug. Heparin-induced thrombocytopenia, HIT. HIT is a specific immune-mediated reaction to heparin that paradoxically increases the risk of thrombosis despite low platelet counts. It often develops within 2 days of heparin exposure. It is less common with low molecular weight heparin. Severe cases require switching to alternative anticoagulants such as bivalirudin, argatroban, or fondaparinux. 4. Pure red cell aplasia. This disorder involves selective failure of red blood cell production, while other cell lines remain unaffected. Causative drugs. Immunosuppressants like azathioprine, antiepileptics such as phenytoin, antitubercular drugs like isoniazid, antibiotics including chloramphenicol and penicillins, antimetabolites such as methotrexate, cardiovascular drugs like methyldopa and quinidine, various others including erythropoietin and insulin. Clinical features. Anemia is the primary manifestation. Diagnostic tests such as the Coombs test can help determine whether the mechanism is immune-related. In many cases, red cell production recovers within 2 to 3 weeks after discontinuing the causative drug. 5. Megaloblastic anemia. This type of anemia is characterized by the presence of large, immature red blood cell precursors due to impaired DNA synthesis. Causative drugs. Drugs implicated include antivirals like acyclovir, alcohol, antiepileptics such as phenytoin, chemotherapy agents like methotrexate, antibiotics such as trimethoprim and nitrofurantoin, oral contraceptives and sulfasalazine. Some drugs interfere with vitamin B12 absorption, including metformin, long-term use, colchicine, cholestyramine. Potassium supplements. Clinical features. The condition results from folate or vitamin B12 deficiency. Supplementation with folic acid is recommended, especially in patients on long-term antiepileptic therapy. Important clinical alerts. Administering methotrexate daily instead of weekly can lead to severe toxicity, particularly mucositis. Megaloblastic anemia associated with phenytoin is primarily due to folate deficiency. Monitoring white blood cell counts is essential in patients taking clozapine to detect agranulocytosis early. An increase in reticulocyte count generally indicates a compensatory response to anemia. Key takeaway: hematological ADRs can affect multiple blood components and may range from mild to fatal. Early detection, discontinuation of the offending drug, and appropriate supportive care are critical in improving patient outcomes. Regular laboratory monitoring is essential when prescribing high-risk medications. Answer the Hematological ADRs quiz. 5 questions. Please subscribe, like and share.